Hello, everybody. Today we are going to go over a little bit of the legislation that just recently came out from Medicare regarding what everybody was talking about this past year about the new E&M codes. So it just came out November 1st. I do have a link included here as well. It is 2,400 pages. It is pretty long, but a lot of it actually they're also answering questions that came in. So it is worth a good review. I probably made through at least half of it, and especially since they're talking about a lot of questions, you can kind of skip over some of those if maybe they don't pertain to you. But the big idea is, how is this going to affect everything? We've actually even had questions coming in from people about, well, you know, one of the credentials I hold is an auditor. So what is this going to do to auditing, to people who have the E&M certification? It shouldn't change too much. As you'll see as we're going through, you're still going to need auditors. We're still going to need people with those skills in this job as well. So some of the changes that are coming up don't take place until at least 2019, some 2020, and some 2021. So let me get my page here. So how are the payments made up right now? So currently, we're being paid, the majority of people under Medicare are being paid under the fee schedule, so the fee for service. So this is going to affect our office visits, your preventative office visits, even outpatient surgeries, surgery centers, diagnostic tests, radiology tests, physical therapy, occupational therapy. A lot of those specialists are all paid under a fee for schedule. So, you know, recently they started doing the MIPS and the MACRA, and we had to indicate all of these parameters that were meeting certain criteria in order to receive proper payment or adequate payment without a reduction. So as long as you're meeting this criteria, your payments weren't being reduced. And then they came out with this new plan saying, well, we're going to adjust everything and we're going to pay on certain levels. So it became a little confusing. So this affects a lot of people, from your doctors, your PAs, your CRNPs, your physical therapists. They're all paid under this fee schedule. And if you know a little bit about how that is established, they're based that this calculation that they have for, and is based on the RVUs, which incorporate work, expense, and malpractice. So the biggest portion of that usually is work. The amount of effort and work that goes into doing one of those procedures, or when you look at an office visit, that's why we have different levels, because it requires a different amounts of ability along with that. And you think of some of your procedural codes, you have something like a stent placement or colonoscopy or hip replacement surgery. So depending upon what's involved in that procedure, there's a certain level of work that's determined, as well as an expense that comes along with providing that service to a patient. So whether that's overhead expense, say in an office, you got your lights, your rent, all that kind of stuff, or in a surgery center, the expense of equipment and things that come along with that type of procedure as well. So all of that's based on the RVU. And actually, if you think about it, our rules are pretty outdated. We can use the 1995 or the 1997 guidelines. Well, that was 20-some years ago. So just imagine how much has changed in medicine in the past 20 years. So they're trying to jump up here a little bit. You may have heard recently when they talked about the MIPS and the MACRA, the reason we're trying to do that is we're trying to put more emphasis on actual patient care. They're trying to release some of the burdens from the provider, the additional paperwork, all of the things that need to be done as part of an office visit or a procedure. They're trying to relieve some of that so that the physician can concentrate solely on the patient and providing adequate care. So this is why CMS says that they're coming up with these new rules, is that these rules will reflect a broader administration-wide strategy to create a healthcare system that results in better accessibility, better quality, affordability, empowerment, and innovation. And that is off of one of the websites that I have there, the link there for you. They have an FAQ sheet about some of these changes. So they're trying to make healthcare better for everybody, for all the patients involved, for the providers, their experience. So they're trying to look at what can we adjust rule-wise that allows a provider to be able to treat a patient for their illness, for their problem that they are coming in to be seen for. So this is why they're trying to change a lot of the rules that you see with payment-wise. Now, of course, this is CMS. This is Medicare and Medicaid based. But as you know, a lot of other carriers may follow suit. As of right now, no other carriers are going to change their payment schedule, but you never know down the road what other carriers might incorporate from Medicare. So some of the new rules that they came up with were an evaluation and management payment system that's going to be implemented in 2021. And then reducing some of that clinician burden, they're going to start that next year and then in 2020. So we'll go over a little bit of what that reducing that clinician burden is and what the new evaluation management payment system will look like to begin in 2021. So starting off with some of the clinician burden that they have. So this is what they finalized. Currently, if you deal with home visits, home-based services, the physician uses certain codes, and this comes directly from the CMS regulation on their website. So the beneficiary doesn't need to be confined to a home, but the medical record has to document a medical necessity for the provider to go to that home visit versus that patient coming into an office or having some other kind of outpatient visit. And new for 2019, they're getting rid of that requirement that the provider does not need to document that medical necessity for a home visit. So if the provider, if you're in a rural area and you do a lot of home visits as a primary care or a podiatrist or some other type of internal medicine provider, these home visits will no longer need to be documented for the medical necessity. So the fact that you're providing care is going to be your medical necessity, which is good in a way that when that audit comes around, your records are always having to reflect that medical necessity. So this is the physician's decision that that patient already meets that adequate care for me to go to their home and give them treatment in their home. So if you deal a lot with E&M, some of these you look at and you go, don't we do that already? Or shouldn't we be doing that already? Well, we should, and hopefully you are, but these are now being put as a rule. So in reducing some of that clinician burden, they're talking about your established patient visits. So the relevant information that's already in there doesn't need to be re-recorded. But it should be evident that you reviewed it and you updated it. So if you're using a previous office note, you should have evidence in there that based upon the note from January 2nd, we've updated the patient's medications, or the patient has come in as this problem has gotten more severe since the last visit on April 30th. So indicating that it was reviewed and that you've updated that information and that you've documented those changes. So they're trying to reduce some of the burden by saying you don't have to repeat, you don't have to click and cut and paste and review information that probably half the time is not actually relevant to that patient's visit that they're being seen for today. So they want to reduce some of that burden on the clinician. I think they said anywhere, it's really weird, but I thought it was like 80 additional hours a year is spent on just this paperwork. So it's a lot of extra paperwork, just all this little documentation that a provider has to do in an electronic medical record, which came about to make things easier for the office. So hopefully some of these things you're already doing, but this is what they're going to want to see now. They want to know that that physician has reviewed that information or that provider has reviewed that information. So their documentation of their name referencing that they've updated or reviewed that, or a simple phrase of, you know, reviewed medical record dated such and such date, that's documenting their proof that they reviewed and updated it. For new and established patients, they have said that there's no need to re-enter the chief complaint and any history that's already been documented either by the patient, whether you use a tablet system. When patients come in, they can update some of their medical information on a tablet, which integrates with the EHR system. Or it could be whatever the nurse or med tech or who is working as an ancillary staff member has already indicated in there. So they don't need to re-enter that information, but they have to indicate that they've reviewed it and they've verified that information. So that's very important. You can't just skip over that part. Oh, the patient already did all that, I'll just get to their exam. No, you need to verify that you did review that information. What if that patient was checking all the wrong boxes? What if they thought a check mark meant no and it really meant yes? So verifying that information, because if that patient's indicating incorrect information or the ancillary staff member perhaps missed something, you just don't have to repeat it, but that you do have to verify it. So it's one of the things in reducing some of this paperwork burden that clinicians have at the end of the day. For the new payment system, which will take place in 2021, for established and new patients, there's going to be a single rate payment for your E&M levels 2 through 4. You can still bill 99212, 99213, 99214, but you will receive one single payment, whether you did a 212 or a 214. It isn't going to matter. So that's what it's coming down to, is a single payment rate. There's a separate payment rate for level 5, and those are very complex issues. Think about your E&M documentation for a level 5. I pretty much tell my physicians they should be on their deathbed when they walk in that door, because you need to be an entire comprehensive review of systems, a complete examination of all systems. In order to get that level 5, they need to be looking at every single thing on that patient and everything that's wrong. Their comorbidities, their medical decision-making process must be very high for them to bill a level 5. So of course, you probably may not see a level 5. Even in my field in orthopedics, we don't see a level 5 that often. Typically, if they're a level 5, they've probably gone to the ER if they had that severe of a problem in orthopedics. OBGYN, you may not see it that often. Some fields, you may not see a level 5. Cardiology, you probably can bill a lot of level 5s because the patients coming in there have very complex issues. So it's going to allow a flexibility that the provider can choose whether they want to use the E&M guidelines of 95 or 97, whatever they currently use. They can also use medical decision-making, or they can use time. So there are requirements that are going to be put in place in order to bill along these lines. There has not been guidelines coming out about it as to whether this patient, you can use the 97 guidelines, but that one I'm going to use time. So, but typically you're going to remain consistent. And this is probably something that should be in your compliance manual, that our office utilizes 95 guidelines, or our office is now going to go by medical decision making as a primary factor for medical records determination and evaluation management payment. So it's something that you probably don't want to jump around, and you're going to want to indicate what system you're using so that if you are under any kind of audit, they can already know this. They always go 95 guidelines. That's what I'm looking for. So when you're using levels 2 through 4 for your established or your new patients, you can use the medical decision making, or you can use what you currently use, but there will be a minimum supporting documentation standard for level 2 visits. So you can't just say it's a level 2 and not really document very much. You have to be supported as it is now by your history, your exam, and or your medical decision-making process. So currently for established patients to bill a level 2, you need 2 of those 3 requirements. So they're still going to uphold that you're still going to need at least 2 of those requirements. If you're using time as a basis, just it's the same as it is now. This is required face-to-face time. So documentation supporting your medical necessity, and that you personally spent that required amount of time with the beneficiary. Now, a lot of times when people think of time, you think of the add-on code, the additional consultation code. That can still be used. You can still say counseling is greater than 50% of your visit. But remember, all of that needs to be documented. If you're doing counseling is greater than 50% of your visit, then you have to document what you counseled, the medical necessity to meet the time requirement, and then the total amount of time. So your total amount of time for your visit and the total amount of time that you spent counseling needs to be greater than 50% of that visit. So you can still use that additional code when they go in 2021. There are some other codes that will be added, and I have those included here as well. They are going to have some add-on codes. So you can report that with levels 2 through 4 or with level 5. They may not have a documentation requirement for that. It's usually with your primary care or other non-procedural specialized medical care. So you think in non-procedural, dermatologists, those are doing procedures. Orthopedics, we might be doing a procedure of an injection or some other kind of removal of some kind. So thinking of your OBGYN, cardiology, neurology, some of the other areas that might need additional work came out of that in order to use that add-on code. And I have examples. There will be an extended visit add-on code. So that's going to account for your additional resources required for that extended time with the patient. So additional resources is not your supplies used for a procedure. So that's not the needles that are used for an injection, because that's a procedure. So it's not, it's the physician time, computer time, paperwork, paper time, booklets, brochures, additional things like that, the additional resources. So Medicare actually has on their website, and I'm going to read this here, for a practitioner choosing to document using the current framework of 95 or 97. So they talked about the proposed minimum documentation to bill an E&M visit from level 2 through 5. It could be, they have an example of a problem-focused history that does not include a review of a system or past or PFSH, past family or social history, a limited examination of affected body area or organ system, or like a straightforward decision making measured by your minimal problems, your data review, and the risk. So using 2 of those 3. So if they choose to document based on those minimal problems, based on like MDM alone, your medical decision making alone, the Medicare would only require documentation that supports your straightforward medical decision-making process, which is measured by those minimal problems, the data review, and the risk, or using two of those three. So when they talk about primary care or other non-procedural specialized care, that's your chronic care management, behavioral health. The add-on coding is for your charges, your review, management of the patient. So not everyone is a primary care provider. OBGYNs can be primary care providers. A cardiologist could be a primary care provider. Internal medicine can be a primary care provider. Some people choose to have those doctors that they use quite often as their primary care provider, their PCM or their PCP. So it's not just, these add-on codes aren't just for a primary care doctor, a family physician. They could be any of these other fields as well. So these add-on codes, I chose to choose their table versus retyping all of that information because that's a lot of information. So these will be the new HCPC codes that they're going to add. And the GPC-1X is visit complexity, which is inherent to an E&M associated with primary medical care services that serve as a continuing focal point. So that's your add-on code, or they have a visit complexity associated with non-procedural specialty care. So here they label out your endocrinology, your rheumatologist, urology, neurology, otolaryngology. So some of these are not essentially your primary care, but because they do include an additional amount of time typically seen with the patient, they have an add-on code that you're able to bill in addition to that E&M that will result in an additional payment to the provider for their services that they performed. So they're talking about here a range of 34 to 69 minutes for an established patient. That's a long time. So you can see why if you're using time, you really need to document that time, because 34 minutes, you know, being with one patient face to face with one patient for 40 minutes, that's a long time. So you need to be documenting that medical necessity for that visit. Or 34 to 89 minutes for new patients. And this is your face-to-face time with that billing practitioner. So it's a long time to include one of these add-on codes. When they talk about how long it's spent for these visits, again, you're talking about level ones. We're not dealing with level ones anymore come 2021. So you're doing your level 2 through your level 4. You have your 34 to 69 minutes. And that could be a 2, 3, or a 4. You're billing any of those with that extended G code. But if you have 70 or more minutes, that's when you're going to go back to that prolonged services code, the 99354, where you're going to be documenting your additional information there as to what the counseling was spent with the patient. So this is for your established and your new patient levels. Beginning in 2021, you're able to bill an extended amount of time with the patients. So how does that relate to the providers? And this is where some of the big problem was with providers. So if you look at, and they compared it to 2018. So in 2018, for a level 2 new patient, you're getting approximately $76, where that's going to go to $130 in 2021. And with these add-on codes, you can get an additional $13 added on to that visit as well with that add-on code. You think, great for a level 2. However, a lot of providers probably bill a level 3 or a level 4. So that's $167 they currently get paid. That's going to go to $130. So it could be beneficial in some ways. I have one provider who bills a lot of 212s. He sees a lot of follow-up patients, and his documentation always supports these 212s. So he's going to benefit from this new system, where some of our providers who are always billing a 214, they're going to actually lose a little bit of money. But we're hoping here, and CMS is hoping, that that's not the basis for how a provider bills his services. They shouldn't be billing their services by the amount of money they're going to get, because the reason this is coming about is to provide quality care to the patient. So if you're no longer having to meet all of these medical documentations for a 214, you can strictly say, based on the medical decision-making process that I've used, or based upon the amount of time I've spent with this patient one-on-one, this is quality care that they are providing to the patient, and hopefully they will see that in their payment reimbursement that they will receive, that those patients are getting the quality care they want, and they will keep coming back for more visits because they feel that the quality of care they are receiving from your office is superb, is by far the best that they've received in any office. So that's the hope and the plan, that it's not going to be based upon money, that the provider can actually start to just listen to the patient, listen to their problems, figure out what's going on, and be able to service that patient the way that they need to be. Some things that they talked about looking at in this new rule that they did not finalize yet, and it could come up in future years, they will look at it. They talked about reducing the payment for an E&M service on the same day that a procedure is performed. So as of right now, when you have an E&M office visit and you do a procedure on the same day, you include your 25 modifier and you're paid for both services. So originally they looked at reducing that E&M payment, because how is this all based up? RVUs, the amount of work involved in that E&M and that procedure on the same day. To do the procedure, you kind of had to do the E&M, or to do the E&M, doing the procedure was part of that service you provided to the patient. So they originally looked at reducing that it did not come to play in this new rule. They looked at separate models for podiatry. I don't know if you've ever been to a podiatrist or worked in the podiatry field. It is a lot different. So I actually did podiatry billing for many years, and the services that are given to the patient are a lot of times procedural, but a lot of times, you're looking at their foot. You're looking at one small system that is trying to help the patient. So just looking at their feet. A lot of times you do have to take into account their other medical conditions. A lot of times in podiatry, you are dealing with diabetics. So it is a lot of experience and thought going into your medical decision-making process. So they did not adjust that model just yet. They were going to change podiatry, but they did not yet. And they were talked about actually standardizing that practice expense. Remember, the RVUs was your practice expense, your malpractice, and the work involved, and that formula comes together for the payment amount. So they looked at standardizing that practice expense. That's kind of difficult. You think of a practice in New York versus a practice in Omaha, Nebraska. Forgive me, their work expense is a little bit different, or that practice expense that's incurred. You could have large practices, small practices, based out of a hospital, or all sorts of different types of scenarios out there that would affect that practice expense model portion of the payment. So they didn't do anything with that just yet either. Some other things that were actually included with this new rules that come out is technology-based communication services. So you think of now, if a patient calls the doctor and says, I'm not sure if I should come in, I still have not gotten better from when I saw you last, and and they discuss it on the phone or through messages or however the service might be working. Currently, as it is now, if that patient comes in within the next 7 days, you use that information from that phone call as part of your E&M, so that some of the information that goes into your medical decision-making process, or some of the information you've already received as part of their review systems or history, you can utilize that information. But what they're talking about now is if you do one of these brief check-ins, phone call or whatever, the physician can now bill for that because they're determining, I don't need to see that patient. And if the patient does come in the next 7 days, or 7 days prior, or 24 hours later, then you cannot bill for that service because that determined that was part of your medical decision-making process. But say that you ruled out that that patient doesn't really have an infection after their surgery, or their cough really is in relation to you know, a seasonal allergy and not some other kind of condition dealing with their lungs. So being able to use that information, they can submit a charge for that now. So the theory behind it is they're reducing that physician burden. They're allowing that time that that physician would have spent, that 25-minute appointment slot, can now be given to somebody who does need it, or they're not having to do all this paperwork of, yep, that cough was just nothing, it was just seasonal allergies, you know, take Benadryl and you'll be fine. So they're reducing the burden on the physician and the practice. So they're now allowing these brief check-ins. If they're using, there's a separate code that if they're using images, so if the patient is submitting images from a test or a record, or their own pictures or images or video phone, that you can bill for that service now as well, as long as the information that derived from that service you're providing to the patient, that remote evaluation, you're not saying, come see me tomorrow. Oh, wow, that looks really bad. You need to come into the office. If that's the case, you're billing for that office visit tomorrow. But if they said, yeah, no, that looks good, put a topical ointment on it, you'll be good, they can bill a G code for that service now. All of these, of course, you can bill for statistical purposes, which is why we submit claims to the carriers. Whether they're actually going to be paid is another area as well. However, we submit all of these codes for statistical reasons, that this is the amount of work the physician has performed, so this is what they can bill for. Currently, there's actually added to it, radiologists felt that those radiology assistants were not being utilized properly, so it's going to revert to your state law. So whatever your state law allows a radiology assistant to do is what it's going to revert to. However, this new rule allows for radiology assistants to be used under the physician supervision requirement. So if your state law allows a radiology assistant to perform a certain service, as long as they're supervised by a physician, then they can now be able to bill for that service. But it's going to go by whatever your state law indicates for a radiology assistant. And if you've ever billed outpatient therapy had to include a lot of requirements, just like we do with our MIPS codes, of submitting data to the insurance carriers as to whether somebody's a smoker, or they're, you know, some of the other requirements that we had to be able to submit to the carriers for statistical reasons. Therapy did that as well. And the reason that therapy used to do that is because physical therapy had a cap. On the amount of visits that could be sent and used and billed. So they're now discontinuing that. They've discontinued the caps this past year. Those were removed in 2018. So they're now saying you don't have to report all these functioning statuses anymore as to how the patient is progressing in their therapy. So that is a reducement of the burden as well, because it's a lot of information that had to be tracked and included on claim forms. So that's no longer going to have to be done. Outpatient therapy, by 2022, you're going to be able to see therapy assistants used the same as a physician assistant or a nurse practitioner. Currently, they're allowed to bill for their services depending upon the state and insurance carrier, but they receive a percentage back. So they receive 85% of the fee versus 100% of the fee if it was performed by a physician. Well, the same is going to come true in coming years for physical therapy assistants. So they will be able to provide the services and receive an 85% fee. They will have a new modifier so that you're modifying your claim indicating that the service was performed by an assistant when more than 10% of the services they received are furnished by the assistant. So if the assistant's only helping for a small portion, that charge is still going under the physical therapist or the occupational therapist. It's going to go under their charge or their name for the services rendered. But if the assistant is performing the majority of those services, you would modify the claim saying that it was an assistant performing those services, and effective in 2022, they will be able to receive 85% of the fee. Now, this is all with CMS and Medicare, remember. So some of the other carriers may not be on board with this yet. But just keep it, as long as you know your Medicare rules and your Medicare guidelines, you can understand what sometimes when United Healthcare all of a sudden starts denying claims or all of a sudden starts doing something, oh wait, Medicare doesn't allow that. So I'm guessing now this carrier doesn't allow it either. So a lot of the carriers might start to follow Medicare rules. As of yet, they don't. This is the link for that large document. So this is a 2,400-page document. It's easy to download. I definitely wouldn't print the whole thing, but download and have access to it. Just review it. Just look it over. And even it's interesting even to see some of the questions that people asked, if it's going to affect this type of payment or if it's going to affect their type of services that they provide to the patient, because all those questions that were asked have been answered in this document. So it gives a lot more detailed explanation for some of these new rules that came out, and some examples as well even are included in there. So if it's something that is going to affect your business greatly, if you do a lot of office visits, your providers might be wondering, how is this going to affect us? I heard there's some new rule and we're not going to get paid anymore. Well, that's not the case. So read up on it and understand it a little bit more, and then you can answer those providers' questions that they may have. That was all that I had for today. I'm going to look through here real quick. I think I have some questions. Karen was wondering if nurse visits will be obsolete. Yes. They will not be billing level 1 visits anymore come 2021. So until then, we can still bill office visits for nurse visits. Whether that's replaced with some kind of code, they didn't mention that in their ruling. Whether they will still need to be seen by a provider to meet that level 2, I don't know. They didn't give any reference to that. They're just talking about level 2 through level 5 visits. It did mention the nurse visits in the ruling. So if you'd want to go back and look at that document and click on the link and look for it's in the first half. It's easy to slide through and find what you need. And plus you can also do the Control F for find. It's a PDF document, so you can search out what you're looking for that way as well. They did mention it, but they didn't mention what they're going to be doing with it instead, or if they were replacing it at all. I don't see any other questions. If you do have any questions, again, you can submit it as a topic request on the CCO page. And we do have another Q&A webinar coming up at the end of this month. So if you do have any questions, maybe we can get it answered by then. Or one of the forums as well. If you're a CCO Club member, submit a question through a forum and we can get it answered that way as well. So, all right. I hope everybody has a really great weekend and a very happy holidays coming up.